So many thanks for inviting me, and from the fantastical world of fairy tales to the very different world of science and health, but something which has equal hope for a new way of looking at stroke care. So I'm very, very fortunate that I work in a world where we have dedicated significant resource to dealing with some of the world's most intractable diseases. I work for a company, I work for a company that has decided that it's going to ring-fence $6 billion of funding to develop new technologies to really make an impact in the world of healthcare. And that those technologies have to improve access to quality care at an affordable cost. And I think those are three very, very worthy strategic goals, because without affordable healthcare, the world is going to become bankrupt as we get older and more sick, sadly. And one of the key areas of focus for that $6 billion of funding is stroke care. And sadly, the world of stroke is not where it needs to be, and the outcomes in stroke currently are really very poor. So just to place that in context, 15 million people around the world suffer a stroke each year. A stroke is the blockage of blood vessels or the leaking of blood vessels in the brain, and it's exactly like a heart attack. When you have a heart attack, part of your muscle in your heart dies. Well, the same with stroke. When you deprive it of oxygen, part of your brain dies. And the reality of that is that it causes an enormous amount of death. It's the third largest cause of death. But most importantly, those that survive stroke are left with significant amounts of disability. It's the largest cause of morbidity around the world. And in fact, women particularly are susceptible to stroke. Stroke kills 2 times more, or double the number of women than breast cancer. And yet women don't really understand it. And a recent survey that was done of stroke care showed that 40% of women don't have any fear of a stroke. They don't understand it, but genuinely wouldn't be concerned if they had a stroke. But with these statistics, we have to change that. And there is treatment for stroke, so it's not a hopeless situation. There are clot-busting drugs out there that can dissolve the clots and the blockages in the brain and restore oxygen to those parts of the brain that need it. But currently, only 3 to 5% of people in the most developed health systems get access to that drug. And that's an appalling state of affairs. In fact, in London, they've made significant strides in the last couple of years, and we're now up to about 16% of eligible patients getting access to this drug. But 16% is by far not good enough for where we need to be. So what do? Well, I look at the stroke care pathway, and I try and understand where I can dedicate some of that resource to make a difference. So the real issue in stroke care is time. To get a good outcome from that clot-busting drug, you need to get it into the patient in 3 hours of the onset of symptoms. So time truly is brain in that situation. So you suffer from symptoms, you call the emergency services, you get to a stroke centre, you get diagnosed, hopefully accurately, and then you access treatment. And that whole pathway has to take 3 hours. So some of the things that we're doing to improve and make sure that we capitalise on the 3-hour time frame are 1, public awareness, and I'll go through that shortly. 2, trying to leverage the time in the ambulance to make sure that we diagnose stroke in the ambulance and we don't wait till we get to hospital. The 3rd is more informative imaging, and I'll come on to that. And the 4th is a really way out there approach to stroke, which is mechanical removal of the clot. So going into the brain with a specialised tube to actually suck the clot out of the brain. So those are pretty out there sort of approaches. But let's just start with what we're doing around public awareness. We have partnered with an amazing physician in the US, in Harlem, who has recognised that children are the best way to educate adults. And it's been shown that children retain information very effectively, and between the ages of about 9 and 12 can educate parents to understand what they need to do about their health. And they're living now with their parents and their grandparents, and they can be the conduit to accessing care quickly. So we've partnered with him, and I think we're going to start the video, to educate children through cartoons and through hip-hop. And this is one of the programs that we're currently investing in. Let's try and get the video to work.
What's up, y'all, ladies and gentlemen? My name is Doug E. Fresh. I'm here with the hip-hop doc. Harlem, let's go, let's go. Stroke, stroke. Stroke. He don't sound right, then he's doing the show. Sway when he walks, then he's doing the show. Slur when he's soft, then he's doing the show. Call 911, cause it ain't no joke. Now ask for the face, and A for the arms, X for the speech, and T for the time. Time to do what? Call 911. Time to do what? Call 911. Fact, to be exact, this is not fiction, this is all fact. Kids from the front and kids from the back. This is what we call the brain attack. Now when I say brain, you say attack. Brain attack, brain attack.
So that was one of the, and it's been hugely effective. It's been rolled out across the US and in fact demonstrated to President Obama in the White House most recently, because this is the way to educate adults to access care quickly, to recognize the symptoms of slurred speech, of weakness of arms or legs, and to call 911 or 999 in our situation. So that's one of the aspects. You'll see there pre-hospital stroke cap. As I said, in the ambulance, it's dead time. We could be diagnosing stroke before we get to the scanners in a hospital. And I happened to be talking to some people from our oil and gas business, and what they said to me was that they have specialized technology that can understand whether there are blockages in the pipes of an oil pipe or a gas pipe. And they do it by pulsing little electrical impulses into that pipe. And if there's a blockage, you get a different signal coming out of those electrical impulses. So we said, well, can we apply those electrical impulses to the pipes of the brain and see if there's a blockage there? And absolutely, we've been able to do that. So we've developed a stroke cap that will be placed on the head in the ambulance and pulse little electrical impulses and give indication that there may be a blockage in the brain, which means that we can save time once we get to the hospital. The third thing there is more informative imaging. You get into hospital and you have a CT scan, and that's what the image on the left looks like. It's black, white, grey, and you have to try and interpret whether there's any rescuable tissue from that. So what we've done is started to introduce a much more sensitive form of imaging, whereby you can see whether there is still rescuable tissue there, salvable tissue, which shows up in green. So it may look grey on a normal scan. On this more revised and informative scan, it looks green. And as soon as you see green, there's still time to save brain tissue. And finally, as I said, we're now starting to suck clots out of the brain in exactly the same way that we suck clots out of the heart. But that needs very specialized equipment to give people insights as to exactly what they're doing. You don't want to be sucking brain tissue out of brain, you want to be sucking clots out of brain. And we feel very confident that we're making significant strides in that area. A different area is the fact that a lot of children suffer stroke, and they suffer stroke when they are unfortunate enough to have sickle cell disease. And sickle cell disease is the most commonly inherited disorder in Africa. And they are 200 to 400 times more likely to suffer a stroke, and suffer a stroke when they're very young and they still have their entire life ahead of them. So age 2 is when they start to suffer strokes. And in fact, I know a woman whose son in this country and is under the care of a London hospital has had 14 strokes already, and he's only 15 years old. So we have to do something about that as well. And the numbers are significant. 400,000 babies are born with sickle cell disease and are therefore very susceptible to stroke in Africa. But what we've also realized is that you can use ultrasound, which is usually used in maternal and infant care and for a whole range of other things, to actually image the vessels of the brain and see whether patients are likely to go on and have a stroke. And if they are, they can receive a blood transfusion to try and replace their sickle-type blood with normal-type blood. So what we've done is we've developed technology that can be used in Africa and in rural places so that we can take the technology to the patients and the patients don't have to come to us. And this is now the size of an ultrasound machine that can be used to image the blood vessels of the brain. So instead of that big cart that usually is wheeled around the hospital, we're now working with technology this size. And I feel very confident that this will increase the access to the care that I talked about at the very beginning. And this is not just used for imaging blood vessels. This, is, of course, can be used to image maternal situations where women that are due to have babies. And we're working in a big project in Indonesia and Tanzania to show that ultrasound in the hands of midwives in the most rural areas will help save lives. And that data and that evidence generation is ongoing at the moment. But again, we feel very confident that this is the sort of technology that can really improve outcomes in both young and old alike. So that's my little tour of stroke care. I hope I've left you with a sense that there's hope for stroke. We need to move that figure of 3 to 5% accessing treatment up to 100%, but we feel that we're on the right track to do that. So many thanks for your attention.